Welcome, everyone. Uh, Welcome to our webinar called Leaving No One Behind versus Pushing People Behind. How can we reach those in the back first? So although this is a virtual session, we're kind of doing it in a hybrid fashion because Media and I are actually in New York for CSW at the moment, and the rest of our panelists are scattered all over the world. We have Anna, who's in the UK at the moment. Susan is in Uganda. Buki, who is our Akina Mama of Africa co-organizer of this event, is also based in Uganda at the moment. And then we have another co-organizer who's based in Amsterdam. So we're all over the world at the moment. And yeah, we'd like to welcome you. Thank you so much for joining us. And let's start our webinar. So a little bit of background on this session, right? So as I said, we're at CSW68 this year, where the theme for the year, the priority theme for the year is economic justice for women and girls and all their diversity, which makes this conversation that we're about to have super relevant. The Sustainable Development Goals, as we all know, committed to prioritizing progress for those most marginalized, especially those dealing with structural barriers and accessing healthcare. And yet we have seen time and again that these groups not only are left behind, but they're also being actively pushed behind. So our question here is, how can we ensure that everyone has access to the healthcare they need? And we will be diving deeper into this question. And we're going to also look at the current financial system and how that actively pushes people behind, and also look at some alternatives that we can bring in so that we can address the right to health for all. So can we go to the next slide, please? Thank you. So we have a great panel here today. We're so privileged to have with us. So I'm going to start with Anna. Anna Marriott is the Health Policy Manager at Oxfam. Then we have Media, who's the Global Health Advocate from Wemos, who's with us. And we also have Susan, who is a Youth with Disabilities Council member from Liliane Fonds. She's based in Uganda at the moment. And then there's me. I'm the moderator for this session today. My name is Shrishti Mahamuni. I am an advocacy and ASRHR advisor at Liliane Foundation. And we're all part of the Make Way program, which is a consortium of 6 partners. And we work to address intersectionality and to make sure that all health advocacy is intersectional. All right, so that's our moderators, and that's me, and that's our panel. Today's session outline is going to be, I'm going to start with setting the scene a little bit. Then we're going to go into Susan's presentation, where she's going to talk a little bit about the youth's needs on disability inclusion and health systems. And Media is going to tell us a beautiful financing story. She's going to give us a little bit of a lecture on what financing looks like in healthcare. It's going to be exciting for all of us to learn more about this. Then we have a break for 5 minutes, just to kind of give ourselves a little bit of space, because we're going to be taking in a lot of information in this session. So we're also going to build in this little mental health break for all of us. And then we're going to dive into the SIG development report by Oxfam, which was also authored by Anna Marriott. So we're excited to have the author of the report with us today. And the report is called SIG Development: Why Development Funds to For-Profit Hospitals is Causing Harm and Why They Should Be Stopped. And then we're going to have a little bit of space for Q&A with the panelists. So this is the outline of our session for today. So let's dive in. Okay, so I'm going to start setting the scene with a poem. I think we need to go to the next slide. Oh, no, sorry, go back. All right, thank you. All right, so when we were setting up this session, we said, okay, it's a session on financing, and it's a session particularly on health financing. And then I wanted to start with a poem, and it's like, okay, how do these two things come together? But this poem is really relevant to our session because the poem is called Nobody, and hopefully by the end of the poem, you will realize why it's so relevant to the session. But I want to give a mention to the poet who created this this piece of art. Her name is Aishwarya Potula. She's from India, and we studied at the same university. And she wrote this poem a few years ago during the peak of the COVID pandemic. And I'm really grateful that she created this piece of art that I can share with you today. So I'm going to start reading it. The poem is called Nobody. I am nobody in this country, but soon I will be a number, like my friends and my family. One of the 2 million infected, one of the 5 million hospitalized, one of the 1 million dead. Just like every fallen petal in spring, I am so many, and yet I am nobody. Just like every fallen petal in spring, I am so many, and yet I am nobody. I'm an artist and an engineer. I'm a parent and a lover. I am wealthy and I'm not. I am privileged and I'm not. Just like every woman, I am all of these, and yet I am nobody. Gasping for breath with and without COVID. Bodies aching with and without COVID. No sleep with and without COVID. Scared to death with and without COVID. Just like you, I am everybody, and yet I am nobody. I pray for you, for that is all I can. I weep for you, for that is all I can. I hope for you, for that is all I can. I wear a mask for you, for that is all I can. But when it is time, my friend, I am choiceless. When it is time, it's you versus I. When it is time, it's yours versus mine. But please remember, and I will too, to fight with all you have for your life until only one of us wins and both of us lose. And India wakes up to nobody dead. So this is a poem again by Aishwarya Potula. So this helps us kind of set the scene and kind of get into the space where we realize that what we're talking about is how the current financial system reduces people, human beings, with full, glorious, messy, beautiful lives to numbers in a system, right? And that's what we're going to talk about more today. So without further ado, I'm going to invite our first speaker, Susan, to dive a little bit deeper into the youth needs on disability inclusion in health systems and why that's important. So Susan, welcome. Can you unmute yourself? So hopefully your connection is good.
Yeah, thank you so much.
Thank you. Take it away, Susan.
Yeah. So I'm going to make a presentation on the youth needs on disability inclusion in the health systems. Next slide. So basically, Sabano Susan from Uganda, a self-advocate from Kampala, living with a disability known as cerebral palsy, and a disability youth council member in the Make-Way program, where we made the research on how the youth with disabilities are mobilizing around the world. Next slide. So basically, I'm going to share my experience on health system from my own perspective. I living with a disability known as cerebral palsy. I shake uncontrollably. But my experience was that when I went to the health center trying to get family planning services, the health workers had a negative attitude towards me as a person living with cerebral palsy. They took it that a person who's asexual. I don't have the right of my own, a right to decide for a partner whom to have sex with and whom not to have with. They thought I'm a person who's asexual, and the health workers tended to explain me by my impairment. Okay, they intended to look more at my impairment rather than the person inside me. They never took it that disability, if you understand the person with disability, disability can be more of like part of human diversity. So in most cases, these health workers, they tend to undermine persons with disabilities, having a negative attitude towards them, determining them by the impairment rather than the individual or the person inside them. Next slide, please. So with that, since I'm a Make Way Youth Council member doing our research, we did a research basically on how youth with disabilities in Uganda are mobilizing around the world. So basically, our research was standing on two objectives. One was to identify the barriers and the challenge experienced by the persons with disabilities when accessing this family planning, especially in the health centers. The next objective, we're trying to act the health care's perspective on accommodating disabilities during contraceptives and consultations. Next slide, please. So mainly, we were able to get the different barriers, like the barriers at national policy, at national level, where we came up that we have got these policies, but the policies are not inclusive and accommodative to everyone, especially the youth living with disabilities. We also came up with different individual barriers, like the sex, the gender. So we also came up with different barriers at community level, like the negative attitude from the health workers and the community themselves towards persons living with disabilities. Then other barriers we came up with are institutional barriers, whereby these buildings are not accessible to persons living with different impairments or disabilities. And lastly, we also looked at the economical barriers, which includes poverty. And looking at those different barriers, we're able to come up with 4 findings from our research. One finding was lack of accessibility, most especially in the health centers. Accessibility can be information. It can also mean buildings. Most of these buildings are not accessible, like to the persons with the physical impairment or those who use wheelchairs. Some of these buildings have got ladders, they haven't got the ramps. Then the second finding was the negative attitudes. This is from the community themselves, from the parents or the caretakers of these persons living with disabilities. they tend to have a negative attitude towards persons with disabilities. And with this, the parents seem to be overprotective of their youth with disabilities because of the negative attitude from the community. Another finding, we found that poverty and financial constraints. Most of the youth with disabilities in Uganda are very poor and they can't fend or can't survive in a day because of their disabilities. Here, I can talk more. I got an experience from one of the youth with disabilities living with epilepsy. This girl had no income and she was hungry. So she had to go to a local leader so that the local leader is able to support her with food. But instead, this local leader took advantage of this girl living with a disability and raped her. So in the due course, this girl became pregnant. So she was facing many vulnerabilities as a person. She became pregnant, she's poor, she's the very person living with a disability. So you can see that those are some of the findings you got from the community. Then the fourth finding was on low literacy. What we meant by this is most youth with disabilities are not educated in their communities, so they can't read. And they have low power decision making. Next slide, please. So another finding, the fifth finding, was the religious beliefs and affiliation. With this, in Uganda, we have got the religion known as the Catholic religion, but this religion doesn't allow family planning. When we try to interact with some of the youth with disabilities who are Catholics, they told us for them religiously, they don't agree with family planning. Then the sixth finding was inadequate skills and knowledge. This was from the youth with disabilities. They do not know about the different health care systems. They do not know about the different family planning methods. Yeah, and seventh finding was survivors of violence face extra accessibility barriers, like they are not able to access things like information. If you get some people living with mental disability, this was an experience from one of them. This girl, she is unable to read. And if she reads, she's able, like the information within the shortest period of time disappears off her head. So with that, she only manages it by pictures. And like most of this information is written, it isn't in pictures. So this created an accessibility barrier towards this girl living with a disability. So the eighth finding was lack of an intersectional lens. Most of the youth with disabilities in Uganda, especially those at grassroots, they don't know anything about intersectionality. Next slide, please. So from the above findings, we came up with several recommendations. One recommendation was to utilize the intersectional scorecard tool, as in we recommend that these youth with disabilities are trained on how to use this intersectional scorecard to gather different information from the health workers. And with the information, we can be able to find a solution. The second recommendation was to raise awareness and increase accessibility internally. Yeah, we saw it is good to raise awareness and sensitize the community about disability and their needs for inclusion. Another recommendation was to reduce gender-based violence and sexual harassment. In order to reduce this, we recommend that we come up with these victims of gender-based violence. We train them, and we train them on how to overcome sexual harassment. And we also train them of their different rights on SRHR, so that they can be able to gain their grants and fight for their rights as individuals living with disabilities. Then another recommendation was to promote inclusion of these marginalized youth with disabilities. On this, we thought, if these youth with disabilities would collaborate and partner with different health workers to bring them up in their system, to bring them in, they can be able to be included in the health system. When these different health workers understand them and their different needs for inclusion. Then our last recommendation was to distribute condoms and pads, especially to these adolescents. Yeah, there is a need to distribute condoms because we know persons with disabilities have different rights, like a right to sex, a right to decide which partner whom to have sex with and whom not to have sex with. In those, there may be one who may have HIV, and it is good to give them condoms so that it can help protect them. And the distribution of pads, when we found out that most of the girls face poverty challenges and they cannot fend for themselves, so they find difficulties in buying pads, items like pads to use during their menstruation. So that's why we come up with this recommendation to give them pads. Next slide, please. So I end my presentation by encouraging everyone to make an inclusive society for all. What do I mean by this? I mean this by saying, if you talk about inclusion or inclusive societies, this means everyone is welcome. Everyone is respected and valued regardless of their background or identity. So it's all about creating a space where everyone is important and has the opportunity to participate and contribute. So in conclusion, inclusion in particular is important because it can help to reduce inequality and social inclusion. It can also help to build a stronger community and improve people's quality of life. Thank you so much.
Thank you, Susan. Thank you so much. That was a really comprehensive presentation. Thank you so much for that. And it just highlights for me also the importance of embracing intersectionality when we're talking about economic justice. So now we're going to go into Media's presentation, where Media is going to dive deeper into financing.
Thank you, Srushti. Thank you, Susan. And welcome everyone again. We managed to fix the chat, so I think now you can take it from here and start exchanging in the chat as well. And thank you for improvising already and using the Q&A to do that. So we heard Susan's story, and I would like to start following the thread. Next slide. So from the story of one person, if we start asking many times the question why they don't have access to quality and acceptable services, why the health workers are not there, why the health workers are not trained to treat people with different needs and different vulnerabilities, we end up in the structural barriers. And often these are questions of financing. So a health worker, for instance, might not have the skills to treat appropriately a person because they never received the training. And why did they not receive the training? Because there was not investment in the healthcare. And why there was not investment in the healthcare? Well, maybe because there was not enough budget from the government, because of austerity measures, because of debt, and so on and so forth. And financing might sound technical, but as we heard a lot also in discussions here at the NGO Forum, is a deeply political issue. And that makes it so relevant also in the social sector like healthcare. And of course, the health systems are financed by different actors, both the public and the private sector. And this is where we are going to zoom in today. Next slide. So what we hear almost for everyone when we discuss the challenges of health system and the challenges that people meet in order to access the services they deserve, is that the private for-profit sector needs to play its part in solving the multiple crises that the world we live in faces today. That's a very, very common rhetoric that we hear at global level discussion, at national level discussions, that the private for-profit sector will come in and even save the day. So that's something very common. However, some of us are concerned about that. So, because we think that is a business model based on economic growth compatible with ensuring human rights for those most marginalized? And for those marginalized because of this very model of economic growth that leaves out the human element, the human stories, the human struggles, like the one that Susan described before. And there are different ways to see private sector engagement. It can be services, so private provision of services, provision of commodities. It can be private health insurances, but it's also private financing. And I'm going to focus today to say a few things about that last part, about private financing in healthcare. And private financing can have different forms. And one of these forms, one of these approaches to financing is what we call blended finance. So next slide. The other way. Yes. So blended finance is basically a financial approach that combines two things. It uses public funds to bring in private investments, with the ultimate goal to raise more funds for development programs, including, for example, for health or education or social protection. So this blend that we're talking about is between public funds and private investments. And it's important to note here that public funds are used to attract private investments. So how does it work? A way that it works is that, let's say that a private investor wants to invest in healthcare, and they might need a loan to be able to do that. However, loans are risky. And if an investment doesn't go well, the public funds come in to de-risk the private investor. Next slide. Yes. So one of the ways that blended finance is working is this de-risking of the investment that the private actor is going to do in order for them to feel safe to put investments into healthcare. But this might remove the risk for the private investor, but it brings up another risk for us, the risk of inequitable results when it comes to healthcare, and the risk of what we said in the beginning of the session of actively pushing people behind. So there are different actors that play a role in this. I structure them into 3 categories. So we have the governments, so the relevant ministries, that health, finance, health authorities. We have international financial institutions and global health initiatives like the World Bank Group, development banks, donors, multilateral, bilaterals, and global health initiatives like the Global Financing Facility, Global Fund, Gavi, and so on and so forth. And then we have the actual private sector, which can be healthcare providers, industries, pharmaceuticals, for example, supply chains, and financial intermediaries. Financial intermediaries include equity funds, local banks, and in general, very simply, investors. And you see here that I have put into bold the World Bank Group. And the reason for that is that we have seen that the World Bank has been the main driver of this private first approach in finance for development. So since the Addis Ababa Action Agenda in 2015, the World Bank is actively trying to adopt this approach and is actively trying to attract private finance, including in healthcare. And there is, in the next slide, you will see an image that describes a little bit this private sector first approach, as we call it. And it's also known as the cascade approach. And why is it called a cascade? Because it starts from the questions that you see. I'm not sure if it's readable, but basically, first you see, can the private sector finance something? And then if that's not possible, how can governments enable the private sector? And then if nothing is possible, at the end of the day, we resort to the public financing. So that's the cascade by the World Bank. What we advocate for, and I will come back to that at the end, is a reverse cascade of putting public first. So with this background, I'm going to share with you some findings from a case study that we did with the Make Way program, assessing one example of blended finance. So very quickly, you see here the Global Financing Facility. So that's a global health initiative that has the mission to protect the health of most vulnerable groups, adolescent girls and women. So it's its mission to provide reproductive, maternal, neonatal, and adolescent healthcare and nutrition, which is great. But then the GFF collaborated with the International Finance Corporation, the IFC. What is that? That's the private sector arm of the World Bank. So it's the department of the World Bank that is dealing with the private sector. So they both put resources into a project in Kenya called the Africa Medical Equipment Facility, which very, very briefly, it provided loans to health facilities to buy equipment, which sounds good. But we had the key question. Does this collaboration of the GFF, a global health initiative, and the IFC, the private sector arm of the bank, contribute to increase healthcare access for the poor and for universal health coverage. So that's what we were trying to find. And we did that study quite early when this project started. So I think we will have more to learn as we go. And our key findings were the following. It was good. Yes, it allowed private facilities to access more financing to purchase equipment, which sounds like a good thing. But the choice of equipment was very limited, high-end and expensive. So it wouldn't be the primary healthcare services that vulnerable groups really need. And it aimed to finance affordable care in small and medium health entities, especially in the primary healthcare level. But what was considered as small and medium by the IFC standards in Kenya was more relevant to the medium to large providers. So that was an issue there. We saw that, yes, there was the willingness of this project to work with more affordable manufacturers, which was positive. But at the time, only we saw large international manufacturers expressing interest participating in this project. So not local, no lower cost manufacturers. So as I said, one of the GFF's key areas of interest was to support the most disadvantaged population and close health inequity gaps. But we saw that the loans through this project were unlikely to benefit the small, low-end healthcare providers that usually the low-income populations reach out to access healthcare, and mainly through the public sector. So in conclusion, we know that poor and vulnerable populations are usually accessing health services in small primary healthcare facilities in the public sector, as I said before, and especially for reproductive, maternal, newborn, child, and adolescent health. However, the bankable projects, so the profitable projects, are big hospitals, are not these small facilities. So the risk there is that financing facilities focused on private healthcare could hamper progress towards health equity because it doesn't invest in the actual facilities that provide that. So what is all this blended finance mean for the healthcare sector? Using development money to attract private investment in specific areas that are considered strategic for the health system, it's okay. But this money could also be used to pay healthcare workers, build health centers, buy medicines. So in the end, basically contribute to equitable access to health services. And our question was, does this approach, does this blended finance approach really contribute to that? So that's what we are concerned of, and that's what we keep on trying to assess through the studies. And actually, there are many resources that have similar suggestions and findings to us. And I have a list of them. You will see them in the screen. And the last one you will see is actually the one that our colleague Anna from Oxfam is going to speak about. And you will hear really, really real examples of how privatization and commercialization of healthcare impacts the lives of people. Because in the end, as also Shruti said in the poem, we are talking about bodies, about people. So I will close with my call to action, let's say, that it's important to prioritize equity over economic viability when we involve the private for-profit sector in health, and opt for a public-first approach. So thank you very much for listening. And Shruti, over to you.
Thank you. Thank you so much, Media. That was a really insightful presentation. And I've also seen in the chat that folks are also commenting on how fantastic this presentation was. So especially for those of us who don't have a health financing background, this is really helpful to understand a little bit about sort of the technicalities of what we're talking about and why it is problematic, right? So thank you so much for that. We said we would have a small break. So let's go into our 5-minute break. This was a lot of information. So, you know, take a break, walk around, you know, get a cup of tea and just sort of let it all sink in. And we'll come back after 5 minutes. I hope y'all are back and that the little break was useful and helpful, kind of have information sink in. We're going to go on to the next part of our session, and I'm going to invite Anna Marriott to please come and take the mic and also present your amazing report, Sick Development by Oxfam.
Thank you so much, Shrishti. And I think I'd like to start really by also thanking Susan for giving us that most important perspective, the human experience of how inequality and discrimination in healthcare plays out. And to Miria then for giving us such a clear and powerful explanation of how profit maximization in the health sector acts as a very significant driver of inequality. And in my presentation, I really hope to marry these two themes together to show again the human face of this big dominant trend in the development sector, in our health sectors, and in our economies in general, in which the objective of profit maximization is permeating all aspects of our lives, even those we consider sacred and are fundamental to our well-being. And how this objective of profit maximization in health is coming at a direct cost to human rights, to rising inequality, and to pushing people further behind, exacerbating rather than challenging the inequality and discrimination that we experience in society and in our healthcare systems. So if you could move to the first slide, please. I wanted to start today with the stories of two women in two different countries. The first is Francisca. She's a young woman from Kenya. Her mother died of meningitis at Nairobi Women's Hospital. The family could not afford the bill, so the hospital refused to release Francisca's mother's body for burial. They locked it in the morgue in the hospital for 2 years. Each day, the bill escalated further. The second woman is Eva. She was advised to take her mother for emergency care to care hospitals in India. There, her government health insurance card, which entitled her to free healthcare, was unjustifiably rejected. She was tricked by the doctor into buying private health insurance, which didn't cover any of the healthcare bill. Eva said she felt threatened by the doctor. The hospital bill cost the equivalent of 7 years of Eva and her father's entire income. They sold everything they had and took out enormous debts. Eva said that every aspect of her life had been destroyed by this event. Now, connecting these two women and many others that Oxfam interviewed is that the hospitals they sought treatment and care from are being funded by the World Bank's IFC, the International Financial Corporation, alongside development institutions of other European governments, including the UK and the French government. The funds being used to fund these hospitals are supposed to fight poverty and achieve the globally agreed Sustainable Development Goals. The development institutions, like the World Bank's IFC and the UK's development institution, which is called BII, claim that these investments in private hospitals will reach lower income patients and help to advance universal health coverage. But our research at Oxfam finds the very opposite. Next slide, please. Oxfam very much identifies the World Bank, just as Wemos does, as a driving force behind this increasingly dominant narrative that Miria talked about encouraging and financing a greater role for the private sector and crowding in private finance, and saying that this is essential to achieve universal health coverage. We find it's a narrative that serves well the interests of wealthy private investors and corporations looking to expand and make their fortunes in lower income healthcare markets. But it is a theory that is countered by the evidence, and when put into practice, brings with it significant and very serious harm, both to patients and to healthcare systems. That the IFC and the other development institutions have been almost universally silent on these risks is hugely irresponsible. So my objective is to present to you the evidence from Oxfam's research of how this narrative and theory is playing out in practice, to examine the performance of these development institutions, including from the UK, France, Germany, and the European Investment Bank, and to assert, with our extensive and wide-ranging evidence of this performance, that healthcare provision is just not a place where these private sector focused institutions should be doing business. And our investigations have been painstaking. We have tried to follow the money between these development institutions and their investments to the private hospitals delivering care across Africa, Latin America, and Asia. Trying to follow that money was unacceptably difficult due to enormous transparency and accountability challenges for each of those development institutions. However, we did follow that money, and we did get to those hospitals, and the evidence of what is being provided by those hospitals was amongst the most harrowing research that I have ever been involved in. If you could move to the next slide, please. So in the hospitals that are being funded by the World Bank's IFC and the other development institutions, we found many cases of alleged or confirmed human rights abuses. This included patients imprisoned in the private hospitals until bills were paid. For example, we identified cases of newborn babies being detained in the hospitals when maternity bills could not be paid, and a secondary school student held hostage in one hospital in Kenya for 11 months. We found multiple cases of these detentions taking place. We found patients like Eva, interviewed by Oxfam in India, who were just unjustifiably blocked by 2 different private hospitals from using their government health insurance cards that should have entitled them to free care. Instead, they were pushed into poverty by fees that they shouldn't have been charged. And in India, where many of these development institutions have concentrated their investments in private healthcare, this problem is rife across private hospitals. And the insurance schemes that the development institutions have claimed are the answer to poorer patients getting access to these private hospitals have been systematically exploited by the very same private hospitals. And in fact, the burden of out-of-pocket payments for health, people paying out of their pockets when they should be financially protected, those out-of-pocket payments are actually on the rise, not being reduced by these insurance schemes. We also found many instances of emergency medical care being denied to patients. Patients being literally turned away at the doors of these hospitals, told that they were too poor to attend these hospitals. And unless they were able to provide massive deposits, they wouldn't even be seen by a doctor, even in emergency cases. This included cases of children and women left unconscious by accidents. And we know that such practice is not just morally wrong, it is illegal to deny emergency treatment. We found multiple cases of overcharging, private hospitals pushing unnecessary treatment and procedures on patients to make extra money, and charging exorbitant medical prices. These were all practices that are commonplace. We also looked at the performance of these hospitals during the COVID pandemic. And at the height of this pandemic, we found evidence that World Bank IFC funded private hospitals and those funded by the other development institutions were either closing their doors to patients or charging exorbitant fees for intensive care beds, running into the thousands of dollars, including countries really badly hit by the pandemic, such as India and Uganda. Some of these hospitals even received additional funding from the World Bank's IFC during the pandemic. This included the Maputo private hospital in Mozambique, which charged a $10,000 deposit before a COVID patient was even allowed in the front door of the hospital. This hospital got emergency aid funding from the IFC. If you could move on to the next slide, please. And beyond the problems of patient exploitation and abuse that we identified, Oxfam also systematically collected evidence from all of the hospitals and clinics being funded by the World Bank's IFC with the other development institutions, and found a pattern of investing in expensive elitist care. These hospitals may be delivering the returns required for their investors to keep investing, but they are entirely inaccessible to ordinary people. We collected fees for maternity care services across all of the hospitals and found that the average starting price of childbirth is the equivalent of 1 year's total income for someone in the poorest 40% in the countries where these hospitals operate. This slide gives a range of examples in different countries, all funded by the IFC and other DFIs. Oxfam's research has also found that the model of funding health pursued by the development institutions is dangerously devoid of transparency, accountability, good governance, and any meaningful democratic oversight. Patients, communities, even legislators that Oxfam talked to had absolutely no idea that this foreign government investment was being made in their local private hospitals. Where evidence is available, we found an overwhelming proportion of these investments, a shocking 80%, are actually being made via financial intermediaries, primarily private equity funds. And 80% of these private equity funds are sitting in tax havens. If you could go to the next slide, please. And this obviously raises, this use of tax havens obviously raises very legitimate questions about whether these development institutions are helping companies avoid the taxes that are so desperately needed to fund public healthcare systems in the countries where these private hospitals are operating. Now, this slide provides just one example of what is a very complex and largely invisible web of investments being made by these development institutions. And remember, this is money, this is taxpayer-backed money, this is in some cases aid money being used to invest in a very, very opaque way through this web of investing. And note here, this is an example of investments in just one hospital, and note how many investments are being made and how overlapping they are. The middle section of this diagram in the slightly grey colour are the financial intermediaries, these private equity funds being used by the development institutions. And as you can see, this is not only complex and difficult to grasp, but all of these funds are sitting in tax havens, in this case in Mauritius. Our evidence base raises alarm bells across the development finance institutions' direct investments, but also especially these indirect investments. We've interviewed staff from the IFC and from the other development institutions, and they've told us themselves that they do not have direct involvement in these indirect investments. And given the sensitivities of this sector and the very real risks of harm, this lack of oversight is completely inappropriate. But beyond, our evidence around development finance institutions, the global evidence is also very clear that private equity has been bad for health. The evidence from the UK to the US to Germany shows that private equity firms are plundering vital sectors like healthcare, decimating working conditions and service quality, raising costs for service users and causing real harm, especially for women. And a recent global review of the evidence on private equity ownership of healthcare in the British Medical Journal said that private ownership is often associated with harmful impacts on cost to patients or payers and mixed to harmful impacts on quality. Yet, private equity firms are the vehicles of choice for the World Bank's IFC and for the other government-owned development institutions for their indirect investments in health in some of the weakest and most under-resourced healthcare systems in the world. My final point is that the DFIs, the development finance institutions, provide absolutely no evidence of impact to counter our very alarming findings, and nothing to back up their claims that they are advancing universal health coverage. The lack of measurable objectives and the lack of any credible impact evidence is pretty astounding given the millions, the billions that are being invested in these private hospitals. For example, the IFC, the World Bank's development institution, has been investing in private healthcare in India for 25 years, but our evidence showed that there is not one disclosed impact report over this period. In contrast, Oxfam's sister report to SICK Development, which is called Do No Harm, provides a dossier of evidence of IFC's investments in India going to urban-based, expensive, out-of-reach hospitals over this period, and an extensive catalogue of over 70 cases of court rulings against IFC-funded hospitals for overbilling, price rigging, refusal to treat patients, cases of financial fraud, illegal organ trading, and violations of patients' rights. Next slide, please. So based on the evidence that we have found and our extensive research into the last decade or more of investing by these development finance institutions in the name of advancing universal healthcare, in the name of tackling poverty and inequality, we have found such alarming findings that we can do nothing but conclude that these DFIs should have no business in healthcare. That's not to say that they can't make a positive contribution in other aspects of the health sector, but in healthcare provision, the evidence is so damning that we're calling for an urgent stop to these investments right now. And we are also calling on governments to intervene to urgently commission independent and comprehensive evaluations of this funding by the DFIs, including digging into these human rights abuses that we have uncovered in our research. But also importantly, that these development institutions are forced to take proactive action to remedy any harms resulting from their investments. We're also calling for governments to step up. We know that the private sector exists. We know the private sector will continue to exist. And while we're very clear that we shouldn't see development funding being channeled to these private providers, we do need governments to intervene with really robust regulation to hold these providers to account and make sure that human rights are not being abused. And finally, we call for strong investment in strengthening the public healthcare system that is equitable, inclusive, and universally accessible, and that importantly is free at the point of use, funded by progressive taxation and other progressive forms of revenue mobilization. We need to build the healthcare systems that can be inclusive, that can treat us like human beings and can be human-centered and are not driven by this very dangerous profit maximization objective. Next slide, please. I will conclude by thanking you for your attention, but also for my call to action, which is that I really believe we need to stand together to start talking about how the privatization and commercialization of healthcare is driving inequality, is driving human rights abuses. And we want to take more action, but we can only be effective in taking action if we join hands on this. So I have left my email address there if anyone would like to contact us about joining us in raising voices on this issue, then please do feel to reach out. Thank you ever so much.
Thank you so much, Anna. Thank you so much for this absolutely impressive piece of research and work that you've done, and also for sharing this with us. I was seeing that in chat, a lot of people were expressing their reactions, and I feel the same. I feel it's very infuriating to hear these stories, and it's also heartbreaking at the same time. And it just sort of puts on the spot for me the fact that these spaces that are supposed to be safe spaces, in the absolute sense of the word, are in fact not at all feeling like safe spaces, and that human rights abuses are happening in hospitals is just completely infuriating and heartbreaking. It's really, yeah, it's a lot. And this is also making me realize and think that how healthcare is often seen as a consumer product almost, when it's a human right. Like, we're talking about human rights here. So in all of these conversations, also in different spaces during CSW week, I've heard this call for privatization and this call for profit financing for healthcare. And I feel like we need to share this information broadly, especially the research that you've done, and share it with everybody so that we understand what the implications of this are. And we're talking about healthcare provision, which is a human right for people, and we're not talking about consumer products. So thank you again for sharing this. I want to open up the floor for questions to our panelists, to Anna, but also to Miria and to Susan. You can type your question in the Q&A section on the bottom of your screen, and then I will read out your question. And some folks have said they wanted to share some experiences. If that's the case, and if we have time for it, then we will also give you an opportunity to share your experiences. But let's start with the question. I already saw a question come in earlier. So I'm gonna start with that question. And it's a question by Buki from Akina Mamava Africa. And Buki asks, it's a question to Anna.
Me. It's not me, but it's an anonymous person. So just
it's an anonymous one.
Sure.
Okay.
Yeah.
Thank you for the clarification, Buki. Thank you for the clarification. All right. So this is an anonymous question that's come in, and the question asks, how do these institutions justify investing in private hospitals instead of investing in the public hospitals? So maybe, Anna, you want to take that?
Thank you. Yes, I will. And Miriam may have more to add as well. So, I mean, as Miriam explained, the kind of premise for their justification is that there's not enough public money going into healthcare systems in many countries, and alongside that, there are private actors there that people are using. So they kind of present it as well, it's just common sense that we therefore should invest more in the private sector because the public sector's not working and there's not enough money. So we need this private finance to come in. And by making the private sector bigger, we will be able to get healthcare to more people. But I think this kind of narrative really hides not only the fact that the structural reasons why public systems are starved of the resource they need to deliver truly universal services, and that includes things like debt levels that are incredibly extreme, externally imposed austerity on countries by the likes of the International Monetary Fund, all of these structural issues, as well as this very dominant neoliberal economic ideology that says we should minimize the size of the state and let the private sector flourish, and that's how countries make money, and that's how everyone will ultimately thrive. So there's a lot of kind of ideology behind underpinning this narrative that we see from the development institutions, also forgetting that that we have the highest levels of inequality that we've seen in our lifetime and for generations. And actually, we do have a huge amount of wealth in our economies. The problem is it's trapped at the top, and governments are not intervening to redistribute that wealth through wealth taxes and the like. So there's plenty of resources just trapped in the wrong places. So this is the kind of premise of why they think it's common sense that we invest in the private sector, and that this private finance can make up the shortfall of public finance. What is obviously missing from that is that when private finance comes in, that private finance wants to make a return on their investment, and they want high returns, and especially private equity funds want incredibly high returns. And what that does then is shapes the way that they look at those hospitals. How can they shake as much money out of those facilities to make those high returns? How can they minimize the staff, because that's an area of huge cost for them? What are the different ways that they can strip back those services in a way that can maximize money, including over-treating and over-supplying healthcare to make as much as possible. So the rhetoric is there to help them look like they have positive objectives. The reality is very different.
Thank you for that, Anna. Media, do you have some thoughts to add on this as well?
Just a small thing. Can you mute your side? Yeah. That the other argument as well that we often hear about investing in the private sector, also in healthcare, is which is again ideological, is this notion that the private sector is going to be more efficient, that the private sector is going to bring more quality. So there is this rhetoric as well. Of course, besides the key issue where it's the commodification of healthcare and health seen as a product that is bankable. So yeah, just this small addition on what Anna said.
Absolutely, thank you, Media. There's some more questions that have come in, so I'm just going to read out the questions, and then Media, Anna, or Susan, y'all can see who picks them up. So there's a question by Emmanuel, and the question is, how can the divide in the quality of services between private and public health facilities be bridged?
I mean, I'm not sure how to answer this question because we were not we didn't compare really the quality of services between public and private. Of course there is. And again, as I said before, sometimes we hear that the private sector necessarily provides better quality of services, but of course that's not always the case, because we know that a lot of times when things go difficult, people are referred to public hospitals to save the day. So if we want, let's say, to make in both cases the same quality of services, the same good quality of services, then this will be done with regulation. And when it comes to the public sector, this will come with strengthening the system, with health workers, with equipment, with commodities, with the end policies. Yeah, that will increase the quality of that. And I don't know if you have a different angle on this.
Yeah, no, I mean, I would echo that it is often, there is a perception that you get better quality in private facilities, but actually that is not always the case. And certainly you know, the interviews and research that we did found that people were often getting the wrong treatment or getting more treatment. In fact, you know, sometimes very dangerous surgery was being conducted when it was entirely unnecessary. And so actually what can seem like good quality and seem like really good attention to patients can often be detrimental to your health when the dollar signs are getting in the way of motivation there. And I would say that actually, you know, regulation is an incredibly important role for governments in trying to bring up quality. But unless there is a universal, accessible public system that is free, ideally at the point of use, that people have a genuine choice to go to, I think it's actually very, very difficult to raise quality overall. And what I mean by that is that unless you have a universal, accessible public system, the private sector has nothing to compete against. And so you end up a race to the bottom on quality. And regulation can only do so much. If people don't have that genuine option of a good quality system, then they are often left to the mercy of profit motivated providers. So we think that's an incredibly important way to drive up quality. But of course, that needs the investment, and we need to have a rethink from governments about the importance of investment in healthcare, because funding levels are dismally low.
I see another question that's coming in chat. It's very interesting. It's by Sylvester. And they're saying that some of these private profitable hospitals trace back to powerful and influential government agents and agencies who are mainly profit-oriented. How can we then effectively carry on with this advocacy to make sure things change? And I want to also add on to this question by saying that even during CSW Week, we've been hearing other international NGOs calling for privatization of healthcare. How can we make sure that we do important advocacy also towards these actors to realize basically the dangers of this? So that's two related questions I'm just going to raise. Yeah.
I mean, I think Anna described it as well in the way that they did the research, is that the way to start is to follow the money. And investigative journalism can also do that. Civil society can do that. But of course, you have the barrier of transparency and access to information, which is sometimes very obscured. But uncovering this gives us the basis to demand accountability. And that's exactly the evidence that we need to do this advocacy. And I think I saw it in the chat as well that many people want to connect. Doing this cross-sector is also key. So we might be in the health sector and others might be in the education sector, but following the money back sometimes will end up to the same actor. So cross-sector advocacy can also bring a difference, I think.
Thank you so much for that, Media. I'm seeing that we have just a few minutes left for the end of our session. So I'm going to, let me see. Okay, I'm gonna actually stop the Q&A for now. And I'm going to bring all the panelists back. And we have 4 minutes to end the session. And I want you to quickly, for me, remind us of your call to action. What is the one thing that we want to take away from your presentation today? So please tell us again your call to action and why this session is so important and why the work we're doing here is so important. So I'm going to start again with Susan. We're going to go in the order that we had the presentation. So Susan, if you could please switch on your video again and come back and remind us of what is your one call to action and one takeaway from today's session.
Okay, thank you so much. Once again, I'm Susan from Uganda. So my call to action is let's strive to make and inclusive society for all. What do I mean by this? Let's try to make everyone feel welcome, respected, and valued, regardless of their background and identity. Thank you so much.
Thank you, Susan. Thank you for that call to action. So important. Thank you. Media, can you please go next?
So I will say again that equity is above any sort of economic viability when we are talking about the right to health. So I would like to highlight this and my call to action, because as we said, economics is not technical, financing is not technical, it's deeply political and social, is to decolonize neoliberal economics that have created this structure that causes these human stories that we heard today.
Thank you. Thank you for that, Media. And Anna, what is your call to action? And what is the one takeaway we go home with?
I think, well, I was going to say what's related to the question, the last question that was put in the chat for me to address in this final comment. But that is that, you know, these very complex sounding ideas, or very lovely sounding ideas from our development institutions who are financed by us, the taxpayers, and have an obligation to fight poverty and inequality and uphold our rights and help deliver inclusive, universal public services. What they say about the crucial role of private finance has to be investigated from the perspective of the human experience. And I really want to come back to that the power of stories, the power of our experiences at these facilities, the power of experiencing the door shut in your face from an institution that has been, or from a facility that should be there to provide care. Those are the way that we cut through these technical, ideologically driven debates and say this is wrong. And I think we really have the opportunity to connect with each other by telling these stories and by taking those stories and speaking truth to power. So I guess my call for action is, again, for those that would like to get involved in following the money, in sharing those experiences, we need to work together. So please do reach out to us and let's do more together to challenge these really dangerous practices.
Thank you so much for that, Anna. Absolutely. Let's bring it back to the human stories, right? Like, let's bring it back also to the poem. And in thinking about the poem, let's think about the engineer, let's think about the artist, let's think about the parents, let's think about the human beings behind these numbers, so that we don't reduce human beings and human rights to numbers, but actually think about who it is that we're talking about and the people. So thank you all so much for joining us. It's been a really, really insightful session, and you've all actively participated. So I really want to appreciate you once again for that. In chat, we're also sharing the poem, the information about the poem, and the writer and the poet who wrote this. Her name is Aishwarya Potula, and you can find her on LinkedIn. We have Anna's email in chat. We will also be sharing more information after the session, perhaps also with the slides and the recording of the session. So thank you so much for all of you for being here. And I'm reading the chat right now, and there's just so much activity happening there. I'm really glad that you all could be here and actively participate. Thank you.